I think we will have less fragmented care and more coordinated care across sites. Because even if you're seeing patient X in the clinic and then you have patient Y and they never came to the clinic, you feel comfortable communicating with that practitioner and having a discussion about, I don't really think that that's maybe the right prosthetic component for this particular patient. Could we trial something else, right? Whereas if you didn't have that daily interaction, face-to-face interaction, you might not have that level of comfort.
On today's episode, we sit down with Jaclyn Megan Sions, a pioneer in the field of physical therapy, post-amputation care, and interdisciplinary education. Her journey has taken her from a pediatric PT all the way to leading a groundbreaking limb loss clinic at the University of Delaware. As a mentor, researcher, and hands-on clinician, Megan is reshaping what's possible in prosthetic care and how PTs are trained for this vital area of practice. Under her guidance, Delaware's Limb Loss Clinic is setting new standards in integrative care and training, merging patient care with innovation and evidence-based practice. Today, we'll look into how Megan is navigating this path, the clinic's unique contributions to the field, and the impact her work is having on patients and practitioners alike. This is Ortho Static from APTA Orthopedics. All right, Megan, welcome to the podcast. This is Ortho Static from AOPT.
Yeah, I'm happy to be here.
Let's start with this. You have an interesting journey, and I like telling stories or helping to have people tell stories about interesting journeys. You went from a pediatric physical therapist to leading an interdisciplinary limb loss clinic. That's a span. That's a difference. But I don't know. It sorts to highlight what's possible in our profession with a PT license, and also what's possible when you just really care about something. Walk us through some of the key moments that led you there. That's a cool journey.
Yeah, so I went to physical therapy school at West Virginia University with the intent to be a pediatric physical therapist. And when I got my first job, I was thrilled because I was working in the exact setting I wanted to work in, an interdisciplinary care setting with speech and OT and PT, seeing kids every day and getting my exercise in during the day,
Yep.
an outpatient physical therapy. And after about 2 years, I started to realize I really liked the orthopedic aspect of that patient care. And so I decided I really wanted to take a deeper dive into orthopedics, started looking for residency programs, and came across the University of Delaware, interviewed. They took me, this little girl from West Virginia. So I guess they took a gamble on me, and here I am. I guess that was in 2007. So almost 20 years later, right, in a different role. So I think you walk through doors that present themselves to you throughout your career, and that, I went to Delaware thinking I would do orthopedics, returned to West Virginia and do orthopedic pediatrics. I had the opportunity to be a teacher's assistant in a spine management course and really loved that, and decided to get my PhD to teach. And about halfway through my PhD, decided, well, I don't think I want to just teach. I think I want to help to create some of the evidence that really informs our field. And so I did my PhD, and I was finishing that up and coming out of clinical practice so I could do my postdoc. And they decided they wanted to open an interdisciplinary care clinic with the local providers here to have better care for patients with limb loss. And I said, yeah, I'd be happy to do it. I think that kind of fits within my postdoc's realm. I can kind of explore a different patient population. And mind you, I hadn't really worked in limb loss for probably, since I had arrived at Delaware, other than I did it as a pediatric physical therapist, right? But I had not worked in that space. And so it was a bit of a learning curve, and diving back into the literature, figuring out best practice, and realizing that there wasn't much to guide care. And so we opened the clinic with the intent that we would collect research that would inform patient care moving forward. We would see these patients, and then we wouldn't have anywhere to send them. And so we started to realize that there are deserts for prosthetic care throughout the United States, and especially in our region, in the greater Delaware region. And so we decided we were going to have a training initiative where we were really going to put some effort in to make sure that there were physical therapy students who were getting exposed to patients with limb loss and really getting the opportunity to treat that patient population. So maybe they would develop a passion. And so it kind of spiraled from there. I got my first grant in limb loss and have been doing limb loss since then. So,
And you're still going.
yeah, still going.
So your clinic's mission focuses on 3 pillars: patient care, practitioner training, and evidence generation. How'd you develop those pillars? I mean, as I hear your background, those pillars become crazy clear, right? I mean, it sounds
Yeah.
like you, but what do those pillars look like in practice?
Yeah. So the patient care piece was because the healthcare model is pretty fragmented when patients leave the hospital setting after a limb amputation. And if you look at the data from like limb loss survey data from Amputee Coalition, the patients and stakeholders express that this is a large frustration and they can't get their prosthetic devices covered. And so having this coordinated outpatient care model that really allows for integration and consensus building in terms of what prosthetic components we're going to order and why, and having the patient be involved in that process, I think is really important to empower the patient, right? Because this is a lifelong journey after you have an amputation. It isn't like you get through the first year and you're done,
Yeah.
right?
Yeah.
So
Yeah.
there's a continual learning kind of that occurs. And patients need upgrades over the years, right? And they need to be able to have data to document that they have a need for those upgrades. And so this clinic provides that opportunity. They can come back in and maybe now they're participating in a sport and we can go over sport specific training and get a sport specific prosthesis. So that's how it meets the patient care needs. And it's been really successful in terms of coverage. In terms of training needs, we started with physical therapy students and we've trained over 150 at this point, which, I think is great because that's 150 more people that can treat this population, right? We've trained over 10 PT residents throughout our residency programs here. And we've started to train prosthetic residents as well. So they're getting interdisciplinary healthcare, but in an outpatient setting, which is relatively rare. And they're learning from each other on like, how does the prosthetic device work? And so it's, what are all the things you need to worry about, like sock ply management, things that PTs don't necessarily think about unless you're in this integrated care model. Right. And so we're getting this practitioner training as well and helping really to alleviate some of the healthcare deserts in the US related to prosthetics care. And then the last mission is, related to research, in that we can go out and we can get samples of convenience in terms of patients that have a limb amputation, but they tend to be healthier. They're not the people that are coming to the clinic to receive care on a day-to-day basis. And certainly they're not representative of minorities and underserved populations that maybe have less healthcare resources. And so the clinic actually gives us data on patients that are seeking care with a very diverse patient sample. And what I can say from that is, like, if you look at like what's out there in terms of limb loss research, there's very little representation of females, African Americans, Hispanic population. And so by having this type of clinic, we can have representation of all so that the data actually applies to a larger proportion of the population.
Well, there's a reason that you just recently received an Innovation in Practice Award for a community partnership. Share what that recognition means to you, and then maybe highlight some of the partnerships or practices that make your clinic really unique. I mean, you shared some of those already, but feel free to go a little deeper.
Yeah, I mean, I think it's been a lot of effort in. I mean, it's been a 10-year effort in. So I think it's really nice for the larger community to be able to see that when you put the effort in the long run, you can have recognition, right? Like, it's not going to be immediate recognition. And so I think it helps people to understand, like, this is a viable model. Like, we've shared with many other practitioners across the United States, like this model they've visited. But I think it kind of gives it some recognition that this is a viable outpatient model, right? And I think it speaks to this idea that research can occur within a clinical practice setting, and it doesn't have to be occurring in a laboratory, which I think is really important because that research can be highly relevant, right? I think from a patient perspective, it's really nice for us to be able to tell our patients, like we always say, while we have 7 publications from the data that we've collected, like we're not just sitting on the data, but we're actually getting the data out there and helping to inform care. Like things like patients don't report peripheral vascular disease, and they don't report peripheral neuropathy. About 50% of these patients, but they have it. If you screen them for it, they have it, and those are high risk factors for subsequent amputation. And so those type of things are really important for PTs to understand and know about this population, that they're not going to necessarily check that on the medical history checklist, but you need to look for it anyways. And so I think those are like the small wins that really make it worth it. I think we see a much larger community network. Delaware is a small state anyways, but the patients come back and they participate in the DPT curriculum. So they serve as patient models for our students. So all students in the program, all 64 of them, have the opportunity to work with a patient with limb loss, not just those who volunteer in the clinic. And I think that that is really valuable, and that they're getting the interaction with live patients, right? And not just practicing on their classmates, because it's, impossible to emulate somebody who's lost a limb and their lived experience. And the students get to hear that firsthand from them, which I think is invaluable.
Yeah, we've all used those models in class, and they're nice, but there's no substitute for human interaction and doing it for real.
Absolutely.
Now, your clinic is known for using standardized assessments to track patients' progress over time. They can use this. You can use this data for research or for proving that there's a need for an upgrade. All those different things.
Yeah.
How do those assessments contribute to the research that you're doing, and what impact do you see it having on clinical practice? Research should drive clinical practice. Clinical practice should drive research. It should go round and round.
Right. Absolutely. So when we developed the clinic, we looked at what are called the LCDs, which are the guidelines for prosthetic coverage. And there's all these boxes you have to tick. But we know in clinical practice, that's just not possible, right? But in this type of model, we can take what they're requiring and kind of boil it back to like what's actually necessary over time. So we can slowly weed out the measures that, for example, don't really tell us very much over time because the patient doesn't have any room for improvement or they don't have any room for decline, right? And so those are not the best measures for this particular patient subgroup, if you will. So it allows us to kind of identify subgroups and what type of tests should be used for various subgroups. It allows us to help to prioritize which are the most important measures and at what point in the patient's care. Those measures can differ in that first year post-amputation as compared to 5 years post-amputation, right? And so it does help us to prioritize, which I think is hugely important in this population. We have limited time, and so we have to figure out how do we best use our time to be the most effective. The standardization across time occurs because everybody's required to do a standardized like online like training module before they start. And the purpose behind that is if you administer an outcome measure and you use different language, you might get a different result simply by the language that you use.
Sure.
And so we eliminate those variables by making them read scripts, just so that over time, if it's a different practitioner, we don't have that worry, which lends itself to research, right? Where we know that that was the script that was used. And so if they change in terms of their performance, we can be pretty confident that a change has really occurred.
Now, your clinic is do I have this right? Creating a regional network.
Yeah.
All right. So you'll be providing training for future PTs, prosthetists, physiatrists. First of all, that's great. Can't be easy to do that, right? Simple to say, but not necessarily easy to do. But how do you see that impacting the future of post-amputation care?
Yeah, I think we will have less fragmented care and more coordinated care across sites, right? Because even if you're seeing patient X in the clinic and then you have patient Y and they never came to the clinic, you feel comfortable communicating with that practitioner and having a discussion about, I don't really think that that's maybe the right prosthetic component for this particular patient. Could we trial something else, right? Whereas if you didn't have that daily interaction, face-to-face interaction, you might not have that level of comfort to, make a request for a change, for example, or have like a collegial dialogue about why something might be better. And so yes, a large number of our students do stay in state. And so that creates a nice network where we have referral sources now in the southern part of the state to treat patients with limb loss, which we didn't have previously, right?
Yeah.
So, I mean, and then we have a whole cadre of undergraduates who've assisted with the clinic since its start, and they've entered all sorts of disciplines, nursing, physician's assistant, some go on to med school. And so I think this early exposure kind of lets them see a glimpse of what it could be if they want to do interdisciplinary care in an outpatient setting.
Now, you've clearly embraced growth opportunities, even in areas where you're like, well, I haven't done this in a while. Let's just try it. Even
Yeah.
when they maybe pushed you out of your comfort zone. What advice would you give to students? Or I don't even think it's limited to students. I think it's limited to new PTs, practicing PTs. Really, there's no age limit on it. People who are looking to make a meaningful impact in the field, what advice would you give them, sort of to, not to steal one from Nike, but just do it?
Yeah, I think my mom's probably said it best. And she said, I think sometimes you just jump off the cliff and then you figure out if the water is swimmable. And I said, well, that might be true in many circumstances, right? It's a calculated jump, I think, right?
Yeah.
Where, you surround yourself with resources. If you don't have the resources, you figure out who those resources could be by shoulder tapping other individuals and like using networking and reaching out to people. You know, there certainly is a very large learning curve, and I just leaned on others to learn, right? Because the reality is that we don't have enough people, and so you can't be shy about learning. You just have to find the resources and jump in, and then over time you will develop an expertise in that area.
Leap. And
Leap.
then the net appears. It doesn't actually usually work the other way around.
Yeah.
Well, congratulations on the award. Thank you for being innovative. Even thank you further for sharing the stories of how you were able to do it. Last thing we do on these episodes here at Ortho Static from APTA Orthopedics, we call it Words of Wisdom. Wow. See what I did there? Words of wisdom.
Yeah.
What would you want to leave with your words of wisdom as we wrap up today? Any parting sentiment?
I think just thinking about patients from a more holistic standpoint and recognizing that maybe they're coming in, for example, for the loss of their limb, but there's a lot of other things that are going on in terms of their mental health, how they're coping, their adjustment, and all of those things are going to impact the
Right.
patient's physical function. And so you can't ignore those pieces of the patient's experience. And you just really have to embrace those and be willing to have some difficult conversations in some cases and lean on those who are experts around you to make referrals when necessary so that these patients can have the best outcomes.
The answer is always people,
It
right?
is.
At
It's
the
always
bottom of it.
people.
It's always
Yeah.
kind of, there's the cheat code for life. The problem is usually people, but we're solving the problem with people.
Yeah.
Thanks so much for the innovation. Thanks for doing this, and we appreciate you taking time to share how you did it, so other people can learn from that too. See, you're people, and you're the solution.
Well, thanks so much for having me.